what is the plan? The plan is to start with cortical mastoidectomy, and then we'll do a posterior tympanotomy, followed by a canal wall down mastoidectomy, followed by labyrinthectomy, facial nerve decompression, and then labyrinthectomy to reach the internal acoustic meatus, right? So that is the plan, and I am hopeful that you all know about the cortical mastoidectomy. So what are the landmarks for cortical mastoidectomy? Let's start with. Okay, so first of all, you have to hold the temporal bone in temporal bone holder, and it should be okay. So it should be held in such a way that it simulates the actual patient lying on the OT table, right? So the zygomatic arch should be facing anteriorly, and the squamous part of the temporal bone should be facing superiorly, and the mastoid part should be facing inferiorly, right? So that is how you actually hold the temporal bone, right? And I am sure you all know about focusing the microscope. Okay, so what for the cortical mastoidectomy, we need to start drilling at the cribriform area, right? So the cribriform area is basically located in the area of mastoid, right? So you just find the externodal canal. So this is the externodal canal. You can see. अच्छा ये माइक्रोस्कोप का पिक्चर आ जाएगा वहाँ पे. हाँ. Okay. So this is the posterior canal wall, and this is the zygoma, right? So you just. हाँ मैं zoom in. But this is the minimum. Okay, right. So this is the temporal line, right? So the inferior temporal line, the posterior canal wall, and a line joining these two lines, right? So this is basically the triangle of attack, right? And in between this triangle, you have to drill. The mastoid antrum is around 1.5 centimeter from here, right? The depth of the mastoid antrum is around 1.5 centimeter, and you have to be careful that you do not delineate the dural plate the here superiorly, and delineate the sinus plate here posteriorly, and preserve the posterior canal wall. So that is also important, because we are doing cortical mastoidectomy. It is a canal wall up procedure, and we have to preserve the posterior canal wall, right? So we'll start with the marking of the triangle of attack. So suprameatal triangle and triangle of attack is slightly different. Suprameatal triangle is basically the McEwan's triangle, right? But triangle of attack is a larger triangle which is bounded by the posterior canal wall and the inferior temporal line and the sinus sigmoid sinus, right? So that is the triangle of attack, right? So we'll start drilling, and we'll mark the. This is a hard bone here, very hard. Okay. So this is the superior limit. Can we have another burr खराब है ये इसका? नहीं burr ही खराब हो गया ये. We can have another burr. So the points to be remember while opening the cortical the mastoid antrum, basically doing the cortical mastoidectomy. इसको घुमा दें. अब ठीक है. So points to remember is that we should not damage the dural plate and the sinus plate, right? And you should not damage the elevator hai. So how do you actually you will not always find the mastoid antrum very much pneumatized. So in disease process, the mastoid antrum is very much contracted. So in these cases, when you are trying to open the mastoid antrum, you have a very small antrum, so you can actually go into a pinhole and you can damage the facial nerve. So in these cases, it is important to uh, delineate the sinus plate and dural plate first, and then you do the blade ले लेते हैं. I think blades हो जाए. Anyway, start करते हैं. Okay, so you expose the mastoid properly. Okay. चलो हाँ knives. So we'll just mark the पानी. Okay. Okay, so can you see this here? So this is the superior limit. Here is the posterior limit. And this is the triangle we are actually. And when you are drilling, you should use a larger size burr for opening the antrum. Keep on saucerizing the edges. Don't go into pinhole. Suction नहीं चल रहा. So I mean, when you are drilling, you should always see that you are saucerizing the edges and you are not going into a tunnel, right? That is important. And use the side of the burr to drill. ये सक्शन नहीं चल रहा है. This is not working. सक्शन चल रहा है हमारा. ये राजपाल सक्शन चल रहा है. ये देखना जरा सक्शन. लाइट नहीं आ रही यार इसमें. स्विच ऑन उधर से. ऑन नहीं है यार, वो ऑन नहीं है. हाँ ऑन नहीं है. मैं वही कहूँगा सक्शन क्यों नहीं आ रहा. चल अब आएगा. So if you have any questions, you can ask. So I was talking about contracted antrum. So how to tackle a contracted antrum. So for contracted antrum, it is important that you should first delineate the sinus plate and the dural plate. So even if you actually open the dural plate or the sinus plate, it doesn't have much problem, but you should not be actually damaging the facial nerve, because in the contracted antrum, when you are drilling, the size of the antrum is very small, and you can actually damage the you tend to go anteriorly and can damage the second genuine of the facial nerve or the vertical part of the facial nerve. So it is important that you remain superiorly and posteriorly. Okay. अच्छा ये तो I thought ये तो I mean we have damaged the. So again this is a contracted antrum I suppose. We have damaged the dual plate I suppose, isn't it? Okay, okay. Can I have a smaller burr? So again this is a very contracted antrum and we are not finding any mastoid air cells. So go slowly and try to find. So this is the side of the dural plate and we will go anteriorly. This burr is not working. नया burr है कोई हमारे पास? ठीक है देखते हैं. Yes, it is working. ठीक है. Okay, so I'm trying to find the antrum here, and it is supposed to be very contracted mastoid bone. There is hardly any pneumatization. Okay, so we have to drill more. हाँ वही कर रहा हूँ मैं. आई एम जस्ट थिनिंग द कैनाल. Okay. So again, this is a really very contracted antrum. I have not found any mastoid air cell. So if you have any questions, please. So I can see one cell which is coming here, right? Okay, there are few cells here which are coming in view. So I think I will use a smaller burr now. Okay, so when you are doing a a cochlear implant, in that case you have to actually thin the posterior canal wall, right? So simultaneously you can actually do thinning of the posterior canal wall. Again, in this patient, I mean in this bone, we have a very contracted antrum, so we are not yet able to find the antrum. पानी देना जरा. So one of the landmarks which you should be able to see when you are into the antrum is the lateral seminiferous canal. Okay, I can see now some cells which probably looks like I don't know. हाँ ये नहीं काट रहा है. So you can actually see the depth of the middle layer also, right? And then compare the amount of drilling which you have done in the antrum. Okay, so probably this is the antrum which we have now. Sometimes you can have corner septum. So in when you are opening, you might encounter corner septum, and in that case, the antrum, the false cavity will not be actually communicating with the middle ear through the editors. So okay, so you can see that I am trying to enlarge the and then try to find the editors. Okay, so probably this is our antrum, and let me see if I can see the editors and enlarge it, right? Give me a cell seeker. है हमारे पास एक वो देना बॉल प्रोब हैं ऑल करना है हाँ वी हैव टू ड्रिल थिन करना है हाँ राइट so probably this is the we have to enlarge it more right पानी डालो पानी पानी डालो okay so it is important to use the correct size of burr also when you are doing drilling uh, burr is a three-dimensional structure right so when you are drilling you should keep in mind the all the surface of the burr which are actually moving right so if you are drilling you might be seeing the superior surface which is cutting but the under surface might also be touching some important structure and can cause trauma right so it is important to use a adequate size burr for the drilling okay हाँ मैं वही I just trying to find out suction देना है ना मेरे को हाँ it is not going inside इसको भी ड्रिल कर देते हैं so this is all we can drill okay so we are now in the antrum saline हाँ डालो okay okay so we are trying to find the editors now इसको थोड़ा सा टिल्ट कर सकते हैं क्या ओके कैन वी टिल्ट हैं एक इसको थोड़ा सा हाँ एक मैं आई एम जस्ट शो यू दी okay so it should be like this I want नहीं आ रहा हटाना है इसको so basically when you are drilling you need to actually change the head position also of the patient ओके ठीक है. Okay, so this is the editors which we are enlarging. Okay, so can you see this is the bulge of the lateral seminal canal here, right? And just enlarge it slightly more. This incus है यहाँ पे. So I can't see. I mean, there is no ossicle here. Otherwise, you would have seen the incus here, right? Okay, sorry. So what we'll do now? We'll just we will thin the posterior canal wall now. दिखाने देना मेरे को posterior canal wall थोड़ा बड़ा पर चाहिए. Right. So when we are doing a posterior tympanotomy, it is important to thin the posterior canal wall, and it should be almost like a papery thin wall. So can anybody tell me the landmarks for posterior tympanotomy? Yes, anybody who can tell me landmarks of posterior tympanotomy? Okay, what is facial recess? Boundaries of facial recess. Okay, yes. So basically laterally is the chorda tympani, medially is the facial nerve, and superiorly is the incus basically. And we need to actually thin the posterior canal wall so that we can do a posterior tympanotomy. Say, thinning of posterior canal wall is very, very important. Otherwise, what will happen? When you're doing posterior tympanotomy, you can actually go very much posteriorly and medially and can damage the facial nerve, right? So basically, we are actually making the canal wall thin so that the facial nerve becomes more, posteriorly, and it is medially. And we can drill anterior to the facial nerve basically. These are all Mastoid cells. पानी. पानी डालो. Okay, give me a smaller size bar. So incus is a very important landmark, and when you are drilling, you should actually see the direction of the short process of incus, right? ठीक है. So that will actually point towards the facial now. Okay, so here the incus is absent, but when you have a incus present, the short process of this is here will be the body, and the short process of incus will actually points towards the facial now, right? So and you leave a small ledge of bone and then start doing the posterior tympanotomy, right? So more thinning is required. So generally when you are drilling for posterior tympanotomy, there can be some cell which will actually points towards the posterior tympanotomy, and this is called as Herald cell. But I don't know whether we will be able to find a Herald cell here because it's a contracted bone. And here you can actually use a diamond burr to delineate the facial nerve. So some people will actually delineate the facial nerve, vertical portion of the facial nerve, and be sure that yes, we have identified, and then do a posterior tympanotomy. Okay. So can we enlarge it? Actually में bone है नहीं sir इसमें. The incus is absent here. तो मेरे को smaller bar चाहिए. ये है सेमिफेमोरल बल्ज सर. तो अभी दिस थिन बोन एक्चुअली, and you can actually see chorda tympani also. Let me see if focus नहीं है. This okay? हाँ. So here actually you can use diamond burr to remove bone gradually and identify the nerve. So what is cordofacial angle? Anybody can tell. Hmm. What is cordofacial angle? Yes. So what is the normal value? Yes. So I'm not able to still. Do we have diamond burr? So you need to actually see the cordofacial angle in cases of cochlear implant. अभी मेरे को से और ड्रिल करना है. Hmm. So if the cordofacial angle is very small, is less than 25, you might have difficulty. अभी काफ़ी बोन है. There is lot of bone to be drilled. अभी थिनिंग और ज़्यादा चाहिए अभी कैनाल. हम्म. Okay. So basically, I am trying to find the facial recess. Can I see? Okay. पानी डालो. Is it facial? नहीं. There is hardly any cell. एक मेरे को इससे छोटा भर देना. So if you have any questions, please ask me. हाँ जी sir. That is the bony ledge I am trying to leave between the posterior tympanotomy and the aretus. Fossa incutis basically, yes. So we want to enter into the middle ear. I am not able to. So here is the middle ear we have opened. डालना पानी देना. Right. Yes, yes, yes. Okay, then you identify. Probably this is the portion of the facial now which is. देख रहे हो ये? This is exposed facial now here. Can you see this small opening? So this is the facial actually, right? And then you enlarge it and then try to see the round window basically. Right. So most of the people now are doing actually round window insertion, and when you are seeing, you should actually try to see the stapes suprastructure first. वो promontory का bulge लग रहा है, promontory लग रहा है सर मेरे को, looks like promontory, wide करता हूँ, and so at this point, I mean, you have to actually see in the posterior and the medial part, right, to see the round window niche basically. And you might have to turn the head of the patient. Yes. So when you are trying to do a cochlear implant, you might have to actually position the patient head, right? Also, if you are having problem during identifying, basic problem in identifying the round window niche, you can actually use a endoscope also, right? At this point, yes. Right, I think you can actually see the is it a round window? Let me confirm. Or it's a hypotympanic cell. Suction देना करो छोटा वाला. Fine suction. Okay, so this is a round window. Or can we see the oval window? नहीं यार एक मिनट confusion है. Okay, can you see the round window here? This is a round window, and yeah. So round window niche. Round window is actually three-dimensional structure, right? So you have to actually drill the lip of the round window, right? So for easy insertion, so that there is no kinking. ये नहीं आ रहा है यहाँ पे. Do we have electrode? This stapes and all the ossicles are absent actually. So we are not able to actually. So first thing which we visualize after posterior tympanotomy is the suprastructure and the tendon basically. Yeah, and then you go inferiorly and you'll find the round window niche, right? So that is the area. And for cochlea, so this is a large burr. Like, so for doing a cochleostomy, or we want to do an extended round window membrane, extended round window approach, you need to have a cochleostomy burr. वो नहीं है. So basically this is the point where you actually drill. You have to drill the lip of the round window so that it becomes flat and it becomes two-dimensional. It is right now it is three-dimensional, and there is an overhang basically. So you drill, remove the round window membrane, and then insert the implant. So that is the point. हमारे पास है नहीं ना वो. कॉकलॉस्टमी बर नहीं है, इससे छोटा वाला बर है कोई? अच्छा, सो यार हमारे को वो मंगा लेते हैं सर। हाँ दिख जाएगा, इसको और कर सकते हैं, वी कैन ड्रिल, सो यू कैन एक्चुअली थिन द, हाँ थिन द posterior, basically the this posterior part of the posterior tympanotomy, right? So posterior wall, so you can drill it till the facial now actually, and it's a good idea to use a facial nerve monitor when you are using doing a cochlear implant. चलो ठीक है, so we'll stop here. I think you can start with the dissection. You can do a cortical mastoidectomy and do a posterior tympanotomy and identify the round window uh, membrane, and then you can do a posterior canal wall down mastoidectomy and हाँ तो नेक्स्ट मैं पूरा भी डेमोन्स्ट्रेट कर दें हैं? 3 बजे तक है तो यार मेरे ख्याल से इनको डायसेक्शन का टाइम देना चाहिए ना ज़्यादा। विथ यू, हाँ यू कैन स्टार्ट विद द ड्रिलिंग पार्ट यार। हाँ हाँ इट विल, हाँ यस टाइम कम होगा। एक सर के लिए नया बोन दे दो, एक इसमें यहाँ रख देते हैं। हमें ना ओटी से ना वो मंगा लो, हाँ कॉक्लियोस्टमी पर जो नहीं, एक अलग से जो हमारे पुराने वाले वो है ना इलेक्ट्रोड, वो डमी इलेक्ट्रोड्स, डमी इलेक्ट्रोड्स, और अगर कोई पुराना कोई कॉक्लियोस्टमी बर पड़ा हो हैं करा दो। हमारे रेजिडेंट्स भी तो हैं ये सारे, ईएनटी वाले तो, ईएनटी वाले तो सारे इंटरेस्टेड होंगे, एवरीबडी वुड लाइक टू डू। नहीं यहाँ पे काफ़ी लोग हैं ना, तो कॉक्लियोस्टमी वो, हाँ डमी इलेक्ट्रोड मंगा लो